We would actually begin with the last talk first, because Sanjay commented upon certain things about AI learning and mixing of data of different regions and traditionally, sort of differences of clinical presentations or clinical problems of various racial sectors, whether it be Asian or Middle Eastern or European. Would that have a bearing on the decision making if we have a common registry somewhere? But probably my own take on that would be, if the data is very large, extremely large data set, then probably it could be generalized. But yes, there could be regional factors factored in that AI itself. I would like Dr. Tim and Dr. Kate to also comment upon the same aspects of AI machine learning. What is their take on it in the larger context of decision making in terms of acute care surgery? Any opinions, Dr. Timothy?
That one I'm going to have to pass. I have zero experience with AI work, and I'm still trying to understand the concept, let alone trying to implement.
Dr. Kate, any take on that?
Look, I agree. I'm yet to have personal experience. Having said that, there is a lot of work going on in Australia at the moment, looking at being smarter and better with our use of data. So the biggest challenge that we face is that data is collected in many different repositories, and it's getting them to communicate. So particularly with the introduction of electronic medical records now, that's sort of really been the focus for our part of the world in the last sort of 5 years. A lot of that data is entered, but it is now bringing it into a space so that we can use it for decision-aided support. Mark Fitzgerald published, it would have been over 10 years ago now, on decision-aided support in trauma resuscitation. That that has use in the emergency department at the Alfred, but not elsewhere in Australia that I'm aware. Maybe remotely, I think they've piloted it, but that's essentially the only sort of wide system I've had experience with. I think what going forward, what the challenge that we have in medicine, not just surgery, is integrating our databases. And I think that there is an obligation on behalf of the big companies that are making a lot of money out of this space with the electronic medical records. The two big players are Cerner and Epic. I think, I'm not sure what else is being used in Europe, but they're certainly the big players. I'm hopeful that once we have a solution and we have a product that is able to draw that data, that will be the start of those real-time registries. So those dashboards where you can see what is your activity, what is your length of stay. You can pick those changes. Oh, we've had an increase in deep wound infections over the last week. That's where we will have that power. But I think we're still a little way off that even in the developed space.
Yes, Kate, you're right. I've had the opportunity to use TRNR with Mark at the Apex Trauma Center in New Delhi as a part of the Australia-India Trauma Systems collaboration. An extremely useful tool, I must say. And therefore, it's probably just the beginning of introduction of AI and data utilization for, acute decision-making and fast decision-making. But yes, I think the future is there. We need to find out ways and means how to get the data confidentially, because I've been working on trauma registries for a very long time. And the main problem in India is that we are not allowed to share our data outside India. And therefore, we need to have our servers within India. And there's a lot of issues with patient-related data. And each country has a law and a rule for it. I think the best would be that if you could share a platform and individualize the countries to utilize that platform and generate their own summary statistics, so that the summary statistics can be actually shared instead of raw data. That would be the ideal situation. Anyway, so long. I think I have a couple of questions for Kate and Timothy also in this open forum. I liked, Kate, your statement about decision in trauma is based more on probability than certainty. I think, and that's a reality. I would just like to ask you that in resource constrained settings, especially Asian countries, many Asian countries are not like Singapore and Hong Kong and developed countries. You would not have, advanced things except for the physiological parameters. You would not probably be able to do much in terms of even ABGs are not available in the EDs, lever-side ROTEM or TEG or things like that. What do you think can be one or two or three indicators, clinical indicators, physiological indicators, which can be relied upon for making a decision for, say, going from DCR to DCS? I mean, rolling in the patient quickly into the OR. Apart from his, what do you think is shock index or a modified shock index or a quick other thing would you say for the residents?
It's a good question, and assuming that there is not access to any of those features, maybe point of care ultrasound is potentially, or a DPA in its absence. But for me, I find the most useful indicator is the change over time. So how does the patient respond to that initial resuscitation, whether it's 1 unit of PAC cells, maybe a bit of FFP, or as in Tim's, classic example of returning the blood from the chest back to the patient. If you start to get that response, you know that you're on a winner. But if you're not getting, if you've essentially got a non-responder or a very transient responder, and by that I mean, what is the heart rate doing? What is the blood pressure doing? Simply sitting back and looking at the patient. The first thing I do when the patient rolls in is I just have a look at their feet. Are they motley blue? That's not a very good sign. Are they pale white? That usually means there's no blood left to become motley blue. Some very simple things like that. How do they change over time? And I think it comes back down, and often in a really sick trauma patient, a damage control situation, we don't have time to get to CT. We're just going to go straight to theatre. You may have sent off the ROTEM. You usually don't have the result back. It still takes a while to cook that result. You may or may not have your blood gases. It's probably not going to change what you do that acutely. So already in those cases, it's the art of surgery. It's the art of medicine. It's when all else fails, look at the patient. And as Tariq Razak often says, listen to the cells.
Yeah. Probably you're right, and probably even the acute, sort of patients can be actually divided into two as far as DCS goes. One is the ones whom you just see it and say that he wants an OR, and the other ones are, like you said, give him a pint of blood or a couple of units of fluids, and they would come back, and probably you would have that window of getting a CT scan done. That's where you probably find out that he's bleeding from the spleen or has a pseudoaneurysm or something like that. And then probably you might have time. Dr. Timothy, any of your ideas about the phasing from DCR or from the ER to OR decision making?
Yeah, I certainly agree. If you've got an ultrasound machine, that's probably the most useful, and particularly surgeon-performed ultrasound. It's an extension of your fingers and your ears. But if you don't have that, you've really got to rely on the basics. And you can still make a reasonable assessment about the patient's chest with a chest X-ray and clinical examination. You can make a reasonable assessment about the patient's abdomen if they're conscious. GCS greater than 12, you can clinically evaluate the abdomen. And yes, blood may give you no pain, no thing, but combine that with blood pressure, pulse rate, urine output, what's in the urine, is there blood in the urine? All those clinical parameters that we need to keep in mind, and what's the level of consciousness? The patient who's shocked is going to be somnolent and not compliant. So those things can help you. And then they are indeed bedside dipstick tests that are available that can be used for coagulopathy and so on. I mean, it's nice to have a ROTEM. My ROTEM is in opposite my resus bay as point of care. We run it ourselves. We're not reliant on the lab services. So we can get an initial result within 10 minutes. So while we pull the blood quickly, we start running the ROTEM, and then carry on with the basic primary survey. By the time primary survey is done, we should be able to at least eyeball the screen and have an idea of where we're going. Again, if you don't have that, you've got to rely on the clinical things. Patient who's already bleeding from puncture sites is worrying. Those patients are going to need damage control.
Any experience with the pre-hospital TXA? I know there was a big study going on in Australia and probably.
I think the Australian study is the big one. Our paramedics carry it. Our nurses in the clinics are administering it. And I think it seems to have an outcome difference, but I'll let Kate answer that one because I think she's got a lot more experience.
So I have it on good authority because I had to give our orthopaedic surgeons a talk on this a couple of weeks ago. So recruitment has finished. They've reached their recruitment numbers. That finished a couple of months ago. And I have been told that hopefully we will have a draft manuscript out within 6 months. And so Russell Gruen's still involved with that, with Steve Bernard and a whole host of others. So hopefully we'll see something within the next 6 months.
Great. Coming onto your topic, Dr. Timothy, I think a wonderful exposition of blunt chest trauma, and that to a severe blunt chest trauma. I personally enjoyed it, and so did probably all the panelists here. I think very rightly, each and every topic taken. I was very interested in your slide on autotransfusion, and you would not use a cell saver for it. I mean, it's just an odd question because, we don't use that.
Yeah, so for blood from the chest, and particularly with blunt trauma, there is no need for a cell saver because it's clean blood that's coming out of a cleanly sterile placed chest drain. No reason to do a cell saver. It's abdominal blood intraoperatively, different story. Then you probably need to run it either through the cell saver or through one of the other filter. There's another filter device that's been devised that is manually operated. So you don't even need the fancy cell saver devices. I can't think of the name offhand, but I think it's mentioned in that paper that I wrote. So yeah, there is an option even for lower and middle income countries for abdominal salvage, but chest drain salvage is easy. If you're using a standard underwater device, don't put water in the device, put saline in. And if you really want to, you can put in a little bit of heparin, and you decant the effluent into a drip bag, and you put a blood-giving filter, and you give it back to the patient. You're not giving them anything they don't already have in terms of infections and stuff.
Anyway, thank you so much. Another question which I had, especially from your presentation, obviously now the whole, I wouldn't call it fad, but about the surgical stabilization of rib fractures, and you very nicely, categorize that into immediate indications and then probably not so immediate indications. And obviously the indications for surgical stabilization have been increasing since the time it actually came up as an option for blunt trauma, chest or multiple rib fractures. Would you suggest that opening up the indications too much would be an overdue for surgical stabilization, number one, especially in those cases where only probably pain is an issue, or you would still say that pain is a significant morbidity for which surgical stabilization should be considered actively? And the second question related to that is that you said the ideal timing. So what would be the ideal timing if it is not too acute? For example, if there are no overlappings or ribs going into the lungs and you need to do it very quickly, what would be the ideal timing according to you?
Okay, so the way to look at the planning around rib fixation is you need to look carefully at what your patient population is. So if you're looking at the population that is involved in the ICU environment, most of them will have lung contusion. So they need to first get over the lung contusion before you rush in and do their ribs. The indications are becoming broader, but the sort of consensus is 3 or more ribs with or without flail, significant overlap, but with limited lung pathology, do them early. Those that have significant lung pathology, there's no disadvantage to waiting to between day 10 and day 14 to allow them to get over their inflammatory response, wean off the ventilator, and then you go and plate the ribs. That stabilization of the ribs is very important from a pain control point of view, but there isn't any hard evidence that for 1 or 2 ribs it makes any difference. So at least 3 ribs would need to be plated for it to make both financial and practical benefit.
Thank you, Dr. Timothy. I'll bring in my other colleagues, Dr. Amila Ratanaike. If you've got any questions to our speakers or reactors, and also Dr. Lee is here. Dr. Urara is here, who discussed the infections in orthopedic. Unfortunately, that's not my forte at all, neither orthopedics nor infections, but the talk was really good. And yes, I've been to Japan, and in the Shinkansen, it's a wonderful train. And your hospital is also probably one of the JR, I think, the railway hospital. Dr. Amila, over to you.
Thank you for all the speakers and the panelists for giving ACT a wonderful session. Kind of regarding AI algorithm and the decision making, I have been involved with the St. Mary's attempt at the vascular trauma, extremely vascular trauma algorithm by the Professor Rasmussen and St. Perkins. So there's a bit of a argument between the big data and the thick data. So they have used something called they have combined the big data as well as the expert opinion. But what I have realized with my experiences with the extremely vascular in the wartime, that we do not address the scientific facts that we already not aware of. For example, ischemic time. Ischemic time is still, we are not very aware of what is the correct ischemic time. Is it 6 hours or less? So these kind of scientific, the facts that we are not aware is not addressed by the big data. So the big data gives the perception of the past. But what about the future? Because science is progressing, and the diseases, the pathologies may be differ in future. So that kind of things has to be addressed when we are thinking about the AI algorithms.
Right. Yeah, Dr. Sanjay.
Yeah, as far as AI is concerned, we are using in RAD regarding rapid AI for brain pathology, particularly stroke, for thrombolysis and diagnosing ischemic versus hemorrhagic and all that, because in odd hours you do not have radiologists, you are not dependent on radiologists, and rather there are certain subjective findings like less than a centimeter size hemorrhage versus thrombotic pre-thrombotic phenomenon happening. AI is quite sensitive and specific more than 90% time, and it is having no subjective phenomenon. But yes, as long as radiology is concerned, there is not much bias. But when we are using into the clinical side, there would be a bias of race, geography, age group, and so on and so forth. So if we can have a universal big data which has a sample size of almost all such kind of factors, then there would be less of pitfalls. That's what.
Yeah, and also of resources. I mean, you enumerated many things. The resources are must, because for clinical decisions to actually manifest into a reality, you need resources. So if AI says you do certain things and they're not available, then you're again. So we need to think about it probably more harder than what it is right now. If there are any other pressing questions on the Q&A, otherwise we'll bring it to a close. Okay, let me thank all the speakers, the reactors, our moderators, and the panelists here once again for a wonderful session. Once again, apologize for the technical glitch we had today. And believe it or not, in 18 sessions, this was the first time which we had such a glitch. We hope that we will not have it in future. We'll stop the open forum now and probably go on to the awarding of the certificates.